All right, good afternoon, everybody. My name is Garrett Schmidt, and I'm the managing editor for ACO Exhibit Hall. And I'd like to welcome you all to today's webinar hosted by Trella Health called Building a Winning Network, Key Insights and Implications for ACOs. And this is a great topic. I'm very excited to hear from our speakers today. A couple of items of note before we get started, some housekeeping stuff. All of you who have joined as attendees are in listen-only mode, so you don't need to worry about muting your microphone. That's been done for you. And also, the webinar is being recorded, so you will have the opportunity to rewatch the session after the fact. In fact, I'm going to send it all of you an email afterwards, and it'll have a link to the recording, also where you can download the slides and whatnot. During the webinar, we'd love to hear from you, so we certainly want to get your questions, and we're going to have a time to do that during the Q&A at the end. There is a question module on your attendee panel that you can use to submit the questions there, and we'll get to as many of those as we possibly can during the time allotted today. And if we don't get to yours, though, it's okay. We'll make sure to get back to you via email afterwards to answer your questions. Without further ado, I wanted to introduce our speakers today. The first is Kristen Reed, who's the Product Marketing Director with Trella Health, and also Rebecca Molesworth, who's a VP of Product Management, also with Trella Health. So I think Kirsten is going to get us started off. So welcome, Kirsten.
Great, thanks so much, Garrett. We are excited to be here today and talking to you all about what we have learned through conducting some market research about ACOs and how they're building high-performing networks. For those of you who aren't familiar with Trella Health, we are the leading provider of acute and post-acute performance and outcomes analytics data. We have some of the largest home health, hospice, and skilled nursing facility organizations that we are proud to call our clients, with over 10,000 users and approximately 250 customers. Part of what makes our solution so unique is that we are an innovator with CMS, which allows us to have access to 100% of both Part A and Part B Medicare fee-for-service claims data. We also recently launched our initial release of Medicare Advantage data, and we'll be updating our products with additional MA data soon. Every year, our data scientists crunch more than 1.2 billion claims for more than 62 million Medicare beneficiaries to bring our customers the most recent and complete performance analytics data. Okay, so today we're going to talk to you about a couple of different things. First of all, we'll set the stage for how the pressures and movement towards value-based care is really focusing or allowing a focus for network growth on behalf of ACOs. So the acceleration towards value-based care and how quickly that is moving and the market is moving that direction is really causing a change in how accountable care organizations think about building out and growing their networks. Then we'll cover the market research goals that we set out with, as well as some information about the participants who were respondents in that market research. So give you an idea of the ACO leaders that we were privileged to hear from. Then we will talk about our key findings and insights. So what are ACO leaders considering their top priorities? How come post-acute care partnerships are becoming more important? Why now, and why are those so important? And then what types of tools are needed for ACOs to effectively build and manage a high-performing network? And then we'll have some time at the end for your questions.
So as Kirsten said, at Trella Health, we really are focused on helping organizations thrive as our market shifts towards value-based care. And we do that in three major ways. We are all about transparency in performance. And as Kirsten mentioned, we look across a very broad network. And we're able to take a market view on performance, so lots of benchmarking comparisons. And with that, we're trying to improve outcomes and, of course, lower costs while delivering high value care. And so just to talk a little bit about what we're seeing in the market and what we heard from our ACO leaders that we spoke to about how the market's shifting. There's a great quote from Mike Levitt, who is a former HHS secretary, where he said we were about 20 years into a 40-year healthcare transformation. And it sometimes feels like 40 years, I'm sure, for those of us who've been doing this for a while. But what's been happening lately that's been really sort of pressing the point on the market has been the policy and regulatory changes, obviously, that are coming through our federal government and specifically through CMS and Medicare and Medicaid policy. And essentially they have determined they want out of the fee-for-service business and they'd like to move more towards a population-based payment system. There's lots of reasons why that's beneficial for CMS in terms of managing care. It certainly makes costs and accountability much more easy to manage. And what that's doing is it's slowly shifting the whole market, because where CMS goes, because they have so much of the dollars in the healthcare systems that are spent, it tends to drive behavior across the rest of the market. And so we're seeing this slow, as Mike Levitt said, transformation of the healthcare system towards more population-based payment. And I'll unpack this slide a little bit for folks. Some of this may be very familiar, others maybe not as much. But as you know, on the left-hand side of our screen, we have sort of the predominant way that care has always been paid for in the United States, through fee-for-service without a link to quality, without a link to value, high quality at lower cost. In order to start that pressure towards transforming the market, CMS started to release some more linked to quality and value fee-for-service payment models, which included things like incentives for putting in foundational work, like we saw in Era High Tech, or paying for performance or reporting, penalties and rewards for how you're performing. PDPM is one that comes to mind for, say, skilled nursing. So there's been a bunch of different kinds of contracts that have been out there in a fee-for-service world that is based on volume, but that is starting to try to introduce the idea that quality and value matters. If you look over on the right-hand side of these slides, you'll see the pink area, which is where we're starting to get more into the advanced payment models. And that's where initially, with things like the ACO programs, we saw advanced payment models that we're trying to build on top of the fee-for-service model. But as we move into the newer ACO models that are coming out, specifically the direct contracting entities that will be launching next year, as an example, you're seeing more comprehensive population-based models. And no secret, the acute part of the healthcare system is leading the way with these models and are being incentivized to lead the way. But we're also starting to see in our post-acute market some of that shift as well. And what this is doing is causing all of these groups to have to care more about how the transitions of care are going, what networks you have, what partnerships are you forming, whether they're preferred partnerships or contracted partnerships. And as you take on more risk, the stakes only become higher. So I thought we'd start our research section of this in terms of, now that we understand more about the market and the way that the market is trending, talking a little bit about some of the anecdotal evidence that we got. And I just thought some of these quotes were fantastic and worth sharing with you because they were pretty indicative of sort of the variability and the sort of noise, if you will, in the market trying to manage a network. So we saw things, everything from some of the ACOs we spoke to were saying they were really having a hard time even accessing data about network potential partners. They would take folks out to dinner. They would have conversations with them about how they performed and how they practiced. But in terms of being able to see data that would help them understand exactly how this provider would contribute to their network, it was very difficult to do. And sometimes it was even difficult to have the conversation with the provider because it's a different way of thinking about data than they were normally used to looking. So we had everything from, we tried to pick the best we could based on a dinner we had together, all the way through to evaluating EMR data and looking at how these physicians are coding in order to be able to understand what the opportunity is for shared savings and whether the kinds of changes they were going to have to make were going to be coding changes, which are easy to train, or were they more process changes, which are much harder to change, practice behaviors. Very different tasks to take on. So we got a very wide perspective from the market and the conversations we had, and it was really interesting to see how these organizations were trying to define a quality network.
Okay, So I wanted to give a little bit of background on why we initially set out to conduct this market research, and then an overview of the different types of accountable care organizations and their leaders who participated. So we were really wanting to get a better sense of the key performance drivers for ACO leaders. And what are the levers that they can pull in their quest to reduce the cost of care while improving quality? And how are ACOs thinking about networks in general? Depends on where they are in the journey, right? So some are more in the early stages and they need to build that network. They're focused on physician recruiting. Others may already have a preferred provider network in place, and it's really about managing those providers and then looking for areas that they can optimize the network. And then how comprehensive are most ACOs networks? Are they primarily focused on primary care? Are they working with specialists as well? And are they entering into contracts with acute care hospitals and that sort of thing? So we wanted to kind of understand that level of variation. And then what are the types of data and tools that they're using to be successful? You know, there's a lot of noise out there, but what are we hearing is going to be the most valuable to them, the data that they have, and then what data would be most useful to them that they don't currently have. So as part of these projects, we were able to get insights from nearly 50 ACO leaders, and some of them were the executive director or CEO of the ACO or organization that comprised multiple ACOs. Others were performance leaders, perhaps vice president of network management or operations, those types of titles. So these are people who are really leading the ACOs that they're part of. And we also wanted to get a broad cross-section of organizations. So that included a range of payer mixes. So everyone that we had participate does have fee-for-service as part of their payer mix, and then others also had managed Medicare, Medicaid, or commercial insurance. So wanted to understand, you know, how does the payer mix influence how they're thinking about building their network, and does it, to what extent does it? Same goes for total assigned beneficiaries in terms of the range. You know, we talked to some ACO leaders who had 10,000 beneficiaries assigned all the way up to more than 100,000. So really kind of a wide variety there as well. And then while most of the respondents were from organizations that had one ACO, there's others that were part of groups that had multiple ACOs within them. So they may be running an entire organization comprised of 10 or more, you know, up to 20 ACOs. Another area where we wanted to seek out some diversity was whether or not the ACO was hospital affiliated or independent and physician led. So we had a fairly even mix there. And part of the reason that we wanted to do that was our assumption was those that are affiliated with hospitals might have access to more data and in a more timely manner than those who aren't. Similarly, talked to folks across multiple payment models and tracks. The most common were participating in basic track E, enhanced track, or track 1, but did have some that were participating in other tracks, as well as some that are planning to participate in the direct contracting entity program. And then there was quite a range as far as experience in taking on risk and capitation. So some were very comfortable and very familiar with that, taking on both upside and downside risk, and others were kind of starting to learn more about risk and how they can participate in value-based care initiatives, but not extremely familiar with it as it stands now. All right, so let's talk about what we uncovered as the top priorities for ACOs. Okay, so the respondents were asked among a series of priorities to pick what were their top 3. And as you can see, you know, there's 2 that really stand out above the rest, and that is managing provider performance and quality, and then controlling total cost of care. So 70% of respondents said that both of those were in their top 3. And then there's quite a drop off to the next one, which was 30% identified improving patient outcomes, and then the next 2, monitoring ACO targets and contractual requirements, and developing a preferred provider network, followed by the last one was recruiting high value physicians. Now, keep in mind, that's just their top 3. So they may have selected, others may have selected some of these as their 4th or 5th, and they're not being counted here. And our sense was, in digging deeper into the data, was just because an ACO selected, only 10% selected recruiting high value physicians or developing a preferred provider network. It was more a matter of they hadn't gotten to that phase of their network development yet versus them not thinking that that was important. So that was the common theme, was kind of depending where they were in the transition to value-based care, they may have had different priorities, but that, managing whatever providers you do have in your network and their performance and quality, as well as trying to lower the overall total cost of care, was something that continually came up in both the quantitative portion of the surveys and qualitative interviews as well. And then I did want to include several that did not make it into the top 10%, but that were listed as ACO leaders' top 3 priorities. So you can see, Rebecca touched on the importance of coding, patient engagement came up, how educated is the clinical team, how are ACOs managing beneficiaries with chronic conditions, what about post-acute care in general, and then SNF utilization specifically came up, and then adequately using analytics tools, which was interesting since, that is something that we provide. So interesting to hear kind of what's working for ACOs in terms of analytics tools and what's not.
Yeah, kind of anecdotally, and I don't think we shared that data though, Kirsten. There was a lot of variability in analytics tools and people's faith in their analytics tools. So it's sort of interesting how fragmented and open the market is right now, was something else I took away.
Definitely, and even those that thought that they were seeing relative success with their tools, that didn't necessarily preclude them from saying they might be looking in the next 6 to 12 months. So we didn't get the impression that there's a clear market leader or dominant player.
Yeah, it's very interesting. Okay, so let's talk a little bit about the critical metrics that we learned about. So, we talked a lot with folks about what is it going to take to really manage a successful ACO? How do you know how your success is, and where do you see patterns that should be either, indicative of good outcomes or poor outcomes, and how do you manage those? And so we talked a lot about cost, and you can see in the example here, we're providing the PMPM and the benchmark that CMS set, obviously very top of mind and very important to the ACOs. And we saw that not only in the interviews, but there's been other studies published by other research groups about, the importance of some of these kinds of metrics in managing the ACOs. Certainly risk score is critical, as well as various utilization metrics such as readmissions, admissions for both ED and inpatient. And then it was interesting, the post-acute care came up specifically around SNF utilization, and then just understanding who actually are the beneficiaries that they're managing. And unlike in an MA plan where you have sort of a selected group of patients and you know who they are and you know where they belong, with the ACO models, most of you are familiar, I'm sure, that patients will churn. And some statistics I have heard is somewhere around 20% annually of your beneficiaries are churning. And so constantly trying to manage and monitor who this population is and what are their characteristics is an ongoing requirement of managing a successful ACO. One of the things in terms of cost that we drilled down with our respondents, our research partners, was understanding not only for their own ACO, but others for comparative purposes. Can you look across the entire market and see what all these different ACOs are doing and how they're performing from a comparison purpose? So definitely in terms of cost. And then managing trends and understanding year-over-year performance. So some of the ACOs that have been around for a longer time, they actually have track record now, and they know how they've been performing year over year. And despite the fact that there is member churn, there are basic trends to how their spend goes. And so the ability to look month over month and see how are they spending, what's the seasonal variability in the data that would help you understand when you expect to spend more PMPM and what time of the year potentially that you would expect to spend less, so that as you're trying to anticipate cost, the ACO administrators have an opportunity to get a sense of how they generally trend to perform, and then how the different physicians that are in their network are contributing to that cost. And one of the things that we learned in the research that I thought was interesting was that not only did they want to know what was happening in their ACO with their membership, which you would expect, right? How are my physicians performing in my ACO in terms of adding cost? But they also wanted insights into what those physicians were doing outside of their individual ACO. So being able to look at a physician and say, wow, your panel is much bigger than the part that's attributed to me. And in programs like the DC program, where voluntary alignment suddenly comes into play, there's an opportunity there for an ACO to go after broadening their patient base, not by adding physicians, but by simply partnering with their physicians that exist to garner more of their fee-for-service population, being able to pull them in, and then being able to look at them from a risk perspective to see, who's outside of their ACO that might or might not be a good candidate for being a part of that patient panel.
Okay, so let's go ahead and move on to the increasing importance of post-acute care partnerships as it pertains to network development for ACOs. So curious for our attendees whether they find this surprising or not, but 95% of the respondents said they were either very focused or somewhat focused on post-acute care, with nearly 60% saying that they were very focused on it. And for some of the respondents, when they provided more detail, they mentioned that this was a relatively new focus for them. So some specifically called out that in 2019 and 2020, and then especially with the COVID-19 pandemic, that it had really forced them to look at post-acute care more closely than they had in the past. So we would be curious to know if this research were conducted a year from now, would that fuchsia piece of the pie be even larger? But it does seem like ACOs and acute care systems in general are recognizing how much PAC provider performance can really alter total cost of care. So while it's not a huge portion of total Medicare spend, it is a key driver of avoidable healthcare costs if not utilized correctly. And then if we move on to the next slide, can get an idea of where respondents ranked the various post-acute care settings in terms of priority. So as you can see, skilled nursing was far and away the most highly ranked. 80% of respondents ranked that as their first priority. 20% said it was their second priority. No one listed that as their third priority of the three. And then for home health, you can see none of the respondents listed that as their first priority. Almost 75% or 3/4 said it was the second priority, and then 30% had it listed as priority 3. Hospice seemed to be the lowest priority of the group, and so they only had 20% priority 1, 10% priority 2, and then 70% priority 3. So that's also something that could be impacted by the pandemic. Be curious to know, over the past year and going into next year, will there be more focus on home health, as we've heard a lot about skilled nursing diversions, kind of how will that shake out in terms of prioritization, but definitely getting the sense that there's areas in all three of these settings for ACOs to optimize their network, whether that's developing a preferred provider network for post-acute care, or really looking at how they can better be utilized.
So as we talked to, I'm sorry, Kirsten, did you cut out for a moment? Are you back?
I think so. Can you hear me?
Okay. Yep, I can. Great. Cool. Okay, so as we were talking to these ACOs about their networks and how they were building their networks, it became really clear that While some folks were still not in the place where they wanted to sign contracts with all different providers in the in the ecosystem, if you will, there were lots of folks clearly focused on primary care, lots of focus on specialty care, focused with relationships with hospitals and how do we keep our folks out of the hospitals, and as Kirsten just was showing, the relationship to SNF and sort of secondarily home health and hospice, if not in a fully capitated model, became less important, but certainly preferred providers were important. And what we found is that the networks that had been a little more optimized, that were a little more curated, if you will, they were taking down the number of preferred partners, especially in the post-acute care space. I think one organization we spoke to went from something like 150 SNFs that they were sending patients out to, pretty much however the physicians currently referred people, essentially, and started trying to narrow that down and had, I think they said 15 or 17 contracts that they were actually signing as preferred partnerships, if you will, with specific SNFs. And they were doing a similar exercise around hospice, and eventually we're going to do home health as well. And so there is this sort of sharpening of that market. And I think my assumption, or what I felt like I heard, and I someone can certainly disagree with me, but qualitatively, it seemed very much like as networks matured, they started to go into more and more post-acute over time. That the first, kind of nut you have to crack is your PCP network. You've got to make sure you know where the orthopedists are and the cardiologists and the folks who are going to care for those patients in the acute setting. But then you eventually need to start getting to, well, how do we make sure we're doing end-of-life care appropriately? And how do we make sure that we're using the SNF appropriately? And if you have a 3-day waiver for the SNF, is that a way to avoid extra cost around ED utilization? And so, the sophistication of the ACO started to make this network conversation even more important and ongoing. And so the ability to be able to go and look over time and continue to curate that network will actually become more important over time. There's sort of a set it and forget it model that some of the ACOs have used, or I'm using all my cliches, spray and pray kind of method, where you get every doctor in the system that you can. We're finding the ones that have been maturing are starting to really rethink that strategy and start looking at how do you really find a network where you have good partnership and you have reliable practice patterns that will help drive the best outcomes.
Okay, so keeping all of that in mind, what are the tools that accountable care organizations need to effectively build and manage a high-performing network? So we asked respondents to get a baseline of the sources and tools they were currently using to provide insights into their network. And then the next slide, we'll talk about some of the other sources that they wish they had access to, or that they would consider if they were evaluating a data analytics solution. So nearly 100% are looking at their CCLF data from CMS, looking at their EMR data, trying to kind of make heads or tails of what that is telling them in terms of how the network is performing. Almost 85% had some sort of data analytics solution, followed closely by a population health platform. And I will say that not all of these are mutually exclusive, right? So there could be a vendor that is providing both that population health platform and then maybe has some sort of data analytics layer add-on, or even some EMRs are offering data analytics add-on capabilities. So it may be that they have one or two solutions that they're getting kind of multiple feeds from. In terms of those that had some type of information exchange, that was just over 60%, a care coordination solution or transition care management solution, around 60% as well. And then 56% were also receiving data from a claims clearinghouse. So really, you can see kind of a drop off in terms of after the CCLF and EMR, just kind of those that are getting claims clearinghouse data or have a care coordination solution probably have more sophisticated networks and access to more data than their peers. And if we move on to the, okay, great. So then we wanted to get a better understanding of, okay, if you're looking at a data analytics provider holistically, what are the types of sources that you would really want to be integrated into that solution to have, you know, for lack of a better term, a one-stop solution, which seems like we're learning more and more doesn't really exist or is very complex to implement. So, you know, 100% are saying that they need that CCLF data from CMS, a very high percentage, 90%, you know, looking for Medicare Advantage data, 80% for, you know, the Part A and Part B claims data from CMS, same with Medicare Part D, so that prescription drug. And a lot of that is to understand, you know, there's certain providers that are prescribing brand name more often than generic when they have opportunities to prescribe generic at a lower cost and still deliver the care that the patient needs. And then talking about post-acute specifically, you know, we have the skilled nursing minimum data set, which talks about things like patients at risk for falling or developing ulcers and that type of thing. So it's kind of a daily measure that SNF patients go through, provides data at the patient level. About 40% said that they would be looking for Medicaid data, and we did find that that was varied a lot depending on the markets that the ACO operated in and whether or not Medicaid had been expanded in their state or states. And then home health, you know, that's another data source that is looking at, you know, outcomes and assessment for home health specific patients. So seeing that post-acute, those data sources being referenced, you know, not quite as high as some of the others, but I think, you know, as post-acute care is kind of getting more of a spotlight and more ACOs are focusing on it, that's another one that we might see grow if we were to repeat the projects in a year or so.
One other thing that, just to jump in real quick, that was interesting, not surprising, but interesting, that when we talk to these ACO leaders, one of the things they've said is a lot of them are looking across multiple, whether you want to call them lines of business or market segments, payer bases. And so this interest in all of the different data was in part driven by organizations that were trying to handle multiple populations from multiple different payers, whether it was commercial, Medicare, Medicare Advantage, Medicaid, trying to manage those patients and monitor them in a similar way. And so the access to the multiple sets of data across the whole entire market became more and more critical as they started to branch out and replicate the practice patterns and the things that they had learned on one population across multiple, so that they could continue to drive value across all of those segments of the market. All right. Well, so I think at this point, what we'd like to do is open it up for questions and discussion. I think, Garrett, you were going to help us with that component.
All right. Yes. Thank you so much. That was a wonderful presentation and a very thorough explanation. We did have some questions that did come through, so I wanted to ask a couple of those in no particular order here. The first one is, was there a marked difference in priorities, quote unquote, between ACOs that generated shared savings versus those that didn't, and what were they?
I can start, Kirsten, if you want to then pick it up. That was what was interesting, is that there wasn't. They were trying to manage and prioritize and structure their ACO to support whatever segments they were in a similar way. And so the kinds of things that we were being asked, when we were asking, people they didn't differentiate necessarily between the lines of business as much as I thought they would. That was actually one of the surprises we had.
Yeah, I would agree with that. And, you know, like we were talking about a little bit earlier, depending on sort of where they were in the stage of their network development, they may have slightly different priorities. You know, if they have a relatively robust network, they may not be as focused on some of the physician recruiting that an ACO that's just starting out would be looking at. But I know there were a number of times when going through the data that, you know, I had to really focus and say, okay, are they talking about their fee-for-service beneficiaries here, or managed Medicare or Medicaid? And so this idea of, you know, getting the patient in the right care setting at the right time, regardless of the payer type, I think is, like Rebecca said, that was something that I wasn't necessarily anticipating would come out so strongly in the findings.
Okay, great. Next question, and again, these are in no particular order. Could you talk about what differentiates Trella from maybe the other data analytics providers in the market?
Sure. Yeah. So I think, well, everyone, Trella in particular looks across the market, and I think that's what I would start with, is that, our point of view and where we start from is how can we compare, how can we benchmark against the entire market? And so not just the slice of the world that our client is living in, but how do we give them transparency across the greater ecosystem? We believe strongly that transparency is necessary to engender change in the healthcare system. And that's part of the mission of what Trella is out to accomplish, is to provide a transparency that actually helps the market self-correct, if you will, towards better quality, better value, better outcomes. That is how we started our business. It's where we orient and where our core is. We also have a very strong post-acute background, which is somewhat unique in this space, is that those areas have not had as much scrutiny and focus because the highest cost dollars tend to be in the inpatient space. But as, again, this network starts to grow and you start to see that the world or the ecosystem of healthcare is coming together, and that a network is not just the PCP and the specialist, it's actually the whole healthcare delivery system. I believe that those strengths and those core capabilities are pretty differentiating in the market.
Yeah, absolutely. And I think that our expertise and the fact we really started out only in the post-acute care space because we saw that was a part of the market that just didn't have a lot of the technological innovations that were being offered to the acute care space. And so, especially if you think about, an aging population, the increasing number of Medicare beneficiaries year over year, those are going to be the patients that are receiving post-acute care for the most part. So, understanding that and then being able to apply that knowledge and kind of move upstream, I think is something that not a lot of other vendors can offer.
Good, great. Another question here is, why do you suppose the ACOs are prioritizing SNFs ahead of home health and hospice?
You want me to start with that one?
Yeah, if you want to start, that's fine. Yeah, go ahead.
Yeah, so I think there's a couple reasons, right? So skilled nursing out of the three is the highest care cost setting, right? So, and in terms of utilization, we see in our trend reports that we do at Trella that home health utilization and SNF utilization tend to be pretty close, COVID-19 notwithstanding. So there have been a lot of procedures that have moved off of the inpatient only list or that have been now able to take place in something like an ambulatory surgery center or other outpatient setting. And that's really causing ACOs and other risk-bearing entities to decide if the patient requires skilled nursing care or if they might be more appropriate for home health, depending on the complexity of the patient and comorbidities. So there's sort of the largest amount of cost savings there if you look from a volume perspective. And then home health, I think that's also another, volume play as well. There just aren't as many patients who are receiving hospice care. That being said, I think there's a tremendous opportunity for ACOs to utilize hospice more. Trella recently did a study on hospice end of life and how there's so much room to save Medicare dollars while improving patient outcomes for those patients who are referred to hospice earlier. So whether they get referred, at the 3-month or 6-month mark, rather than most are only receiving hospice care if they do receive it for less than a month or oftentimes less than 2 weeks. And those patients who are receiving it closer towards the end of their life, they're going to be in and out of the hospital more often, in the ER more often, and they're not going to be able to spend their time with their families. So from, quality of life perspective, but then also a cost perspective, I think most ACOs have an opportunity to better utilize hospice for patients who are terminally ill.
Yeah, I totally agree. Those end-of-life costs where, you know, the traditional hockey stick view of the costs for an individual accelerates so greatly at that point of end of life. And utilizing hospice well is something that I think, you know, ACOs really have an opportunity to do. Totally agree with you.
Okay, next question is, what effects do you think or do you foresee the COVID epidemic to have on home health and hospice?
Kirsten, you should start that one. I'm happy to chime in, but that's
Sure. So
right up your alley.
Published a couple of blog posts on our website recently about this, and we're continuing to dig into the data since we received the first quarter of COVID-19 impacted data. I think what we're seeing so far, and you have to keep in mind that we're still in the middle of this, right? So it's Q4 2020, and we'll be in this in Q1 2021 as well, unfortunately, is that because of the inpatient population going down so much, that did impact, and we really saw a decline in both home health and SNF admissions for the Q2 2020 reporting period. And then, it was sort of this U or V, depending on the, exact definition of those inpatients started to return. So from, March, there was a precipitous drop to April, started to rebound slightly in May, then more in June, and then home health and SNF picked up a little bit as a result, but they're still lagging behind significantly, in particular SNF. And even prior to the pandemic, we had already seen pretty significant declines in both SNF utilization and total admissions. So I think that that is going to continue, and there will be more diversion to home health, and skilled nursing care will really be reserved for those patients who are high acuity patients and require fairly complex care.
It's also interesting because the COVID pandemic has clearly exposed the weaknesses of a volume-driven model. You see that in the primary care outcomes, as Kirsten is describing in our post-acute care space. The places that have done better are folks who are under some kind of capitated regular payment model where their income is more predictable than those practices that are dependent on volume. So to me, I also look at this pandemic as exposing the pain point in the system where that's happening and starting to sort of help fan the fire around how do we shift to more of a value-based care model where the revenue, it might be capitated, but it's consistent and it's more predictable through, sort of an actuarial point of view. I think that this, it hasn't played out yet, but my hope is that this will help us continue to pursue a more value-based oriented system that will be more equitable, I think, in the end.
Yeah, and I'd say in general, the pandemic has really forced the healthcare system to look at post-acute care more closely and understand its importance more broadly. As you had these surges in acute care hospitals, or the potential for those surges based on modeling, it was really the post-acute care providers who were reaching out to their referral partners, letting them know about their ability and capacity to take on more patients. So I think in some ways this has been good for post-acute care providers to really highlight the important work that they're doing and the patient care that they're providing.
Yeah, and that's interesting you say that, because there was other feedback we got that the health systems, instead of being able to spend time thinking about partnerships with post-acute, what COVID has done essentially is force them to lean on whatever relationships they have to find beds available for people who are convalescing, and it is testing the partnerships that health systems have not spent as much time focused on in a post-acute world.
Very interesting. Yeah, well, there's a lot left to see where that all goes. Unfortunately, we are out of time for questions, and so we're going to wrap it up here. Thank you both again so much for the presentation. Again, it was very, very well done and thoughtful, and I appreciated it for sure. For those of you who have submitted questions that we weren't able to get to today, we will make sure to answer those via email. And so please continue to, if you have one at the last minute here that you'd like to submit, go ahead and do that as we're wrapping up. And also, if you have any specific questions for either of our speakers, their contact information is going to be here on the last slide that I wanted to show you. But before we do that, I wanted to encourage you all to head over to the ACOexhibithall.com and check out the Trella Health exhibit booth. We have an interactive booth over there that's really cool, and you can interact with them and their team and connect with them and see what they're doing. Lastly, again, if you'd like to connect with either of them, feel free to reach out directly, and they'll be happy to get with you. I hope you found today's presentation helpful and informative. I know I did. And appreciate all of you attending. I know there's a lot going on right now fighting for your attention, so we really do appreciate your time. So thanks a lot for coming, and have a great rest of your day. Bye-bye.
Thanks so much, Garrett.
Thank you, everyone.
Thanks all for joining. Bye.